This occurs in significantly malnourished patients with sudden increase in calorie intake. You see, when somebody didn't eat for 2 days, let's say for an example, even 24 hours, if you have not eaten anything in 24 hours, after 24 hours, you can't just eat a huge meal right away. You have to slowly introduce food into your blood. Is that clear, folks? If you eat a high meal or carb meal, you will spike insulin, folks. So because why? 24 hours, there was no glucose, and now all of a sudden you are doing hypersensitivity, the insulin spikes, decrease phosphate, decrease potassium and magnesium. The potassium is bad for heart. Okay, bad for heart. Treatment. So when somebody comes with anorexia nervosa, the first thing we do, we admit to the hospital because they need a rehab, folks. Okay, they need all the electrolytes and everything, folks. Okay, so that's anorexia. Now, the next disease, bulimia. We need to know how to differentiate anorexia from bulimia. The easy way is people with bulimia, the key is the BMI is normal or slightly overweight. You see, that's a key. Whereas anorexic people are way too skinny. These people are either normal or overweight. So it's easy when you do BMI, but in the real exam, they never give you BMI. Because if you give BMI, anybody will pick up the answer, right? So here, bulimic patients, folks, recurrent episode of binge eating with compensatory purging behavior, at least weekly over the last 3 months. They're also doing the same thing. Associated parotid gland hypertrophy because of vomiting, enamel erosion, Mallory-Weiss syndrome. What is Mallory-Weiss syndrome? What are the layers involved in Mallory-Weiss syndrome? Type it up. I want what layers involved in Mallory-Weiss. Mucosa and submucosa. Then, over a period of time, it becomes Boyer-Haff syndrome. That's your transmural. Okay, the whole layer. Then you leak into thoracic cavity and all these things. Okay. Now, electrolyte disturbances, same thing here, folks. Treatment, psychotherapy, again, nutritional rehab is the idea, folks. Okay, so that's how you differentiate. Are we clear with anorexic and bulimia here? Next, go to binge eating disorder. So what is this, folks? Recurring episode of binge eating without purging behavior. What does that mean? You eat what you want and you don't do anything. I thought that was normal. That's what I've been doing. So apparently now it's a diagnosis if you do that. You can't just eat what you want, right? So here, if you see, it's basically recurring episode of eating. So you're eating a lot, but then there is nothing, right? So, but the problem is, if you do that, you're at risk of diabetes, right? It's a diabetes. That's the idea, folks, okay? You see, day by day, psychiatrists are adding more diagnoses. Okay.
Dr. Roy, what is considered binge eating? Like how much food is considered binge eating?
Basically, there is no number limit. Basically, the only idea is, technically speaking, they're eating more than 3 times a day.
Okay.
You're supposed to only eat breakfast, lunch, dinner.
Okay.
No snacks, no popcorns, nothing in between, no Pringles, right? That's the Asian lifestyle, right? That's the idea. So that's why, I tell psychiatrists, very soon, like by the time we retire, they will say, like, instead of 1 burger, if you eat 2, that's a pathology, right? So they will because they have to come up with more and more. Look at this, guys, I understand if you eat more, you are at risk of diabetes, right? Now it's a diagnosis, binge eating disorder, right? That's it. So the definition of eating is 3 meals a day. Okay, 3 meals a day. And they said if you only eat 3 meals a day, you will never gain weight or you'll anything because you are giving enough time for intermittent fasting automatically in between. Okay. But the problem in Western countries or US, we don't give that break, right? We walk around, there's something always to take it and put it in the mouth, right? You don't have to eat a lot. All you need is a small piece that will bring this insulin back up, isn't it, folks? Right? That's exactly here the problem. Most common eating disorder in adults. Exactly. That's the idea. Treatment. Psychotherapy. Basically, you go to a therapy, they will tell you don't eat a lot. That's all what all psychotherapy is, basically. Okay. And SSRI and those medication, folks. Okay. The funny part is, you have to go listen to the psychotherapy for like a half an hour. You pay $100 for that half an hour. But on your way back, you will feel hungry and you'll go through drive-through and eat something. Right. So that's the binge eating disorder psychotherapy, folks. Okay. Now, so that's binge eating disorder. Is everybody clear, folks? All right. If you go to some villages, not in the United States, like if you go to some countries and you go to villages, they still practice only 3 meals a day. You don't get nothing. I was in one village and we ate lunch and around 2-3 o'clock and I was expecting a snack to come. Nothing was there. They were like, the next thing is dinner. But that dinner is a hardcore protein dinner, nothing tasty in there. And that's it. Right? But these people are the most healthiest people. They don't have any disease, nothing, everything is perfect. Right? That's it. All right. Now, pica. We already know what is pica, folks, right? It's a recurrent episode of eating non-food substances. Whenever you see a pica, folks, it's iron deficiency. Okay, where is it? Iron deficiency anemia is one of the symptoms. People eat ice, right? They would eat the whole ice and all these things. So that's pica, folks. All right. Give me a sec here. Let's do some questions. Go for it. Now here, see, this question is a little easier because they are giving the BMI. Okay, that should make it easy. 26-year-old woman comes to the office due to recent weight gain. She has eaten more than usual over the last 5 months. She gained 7 pounds and feels guilty. Further questioning reveals that she consumes a large pizza and 2 large bags of chips in one sitting. That's a lot of food in one sitting. Okay. And she does it several times a week. Okay. Afterward, the patient feels ashamed about being unable to control her diet and she fasts to make it up for it. So she's eating and she's doing some compensatory behavior. Is that clear, folks? So that's a compensatory behavior. She's very distressed about being unable to lose weight despite exercising 2 to 3 hours a day, vital signs, and BMI. Now, BMI is normal and she's overweight. So that should rule out this one, not this one, sorry, anorexia. It's not anorexia, right? And what is binge eating disorder? You eat, but you don't do anything about it, okay? It is not body dysmorphic disorder. It is not an adjustment disorder either. So now you are here. This is a bulimia nervosa, folks, okay? Now the question is, what is normal behavior? Normal behavior is basically eating a healthy what you needed for your body, so which is not be an answer to anywhere. So that's bulimia here, folks, okay? See, a lot of people are confused between E and C, right? If I were to tell, if I remove this word, if I remove that compensatory behavior, then you go for C. Very careful. If you feel guilty and then we do something about it, then it's bulimic. But if I don't do anything, that's binge eating disorder because I don't feel guilty. Is that clear, folks? All right. No, I don't know why they give BMI. They should remove those. Look at a BMI, 18. It cannot be bulimia, okay? If it is 18, it cannot be bulimic, folks. 23-year-old woman comes to the emergency department due to right wrist pain after a fall. The patient fell on an outstretched hand while walking across on the floor at a gym where she exercised regularly. She has no significant medical history, no medication. The patient says she avoids eating high-fat or high-carb foods because she wants to avoid getting bloated and gaining fat. Her last menstrual period was 7 months ago. That's amenorrhea. Did we get that? Okay. She doesn't use tobacco, alcohol, or any drugs. Temperature all good. BMI is low. Tenderness and swelling are present over the right distal radius, mostly fracture. By now, you should know this is anorexic type because very low BMI, and that's there's no disease avoidant restrictive food intake disorder, folks. Okay. Now here it's basically anorexic. It is not any of these things. Are we clear, folks? That's the disease. Okay. Now let's see what is B here, okay? Avoidant and restrict food intake disorder occurred by inadequate food intake due to lack of interest in eating. Basically, that's basically you are not eating at all, folks, okay? So that's people with depression, major depressive disorder can possibly happen, okay? That's that. Now here, that's anorexic. All we clear, folks? Now, remember in this question, right, even though it says parotid glands are enlarged, but still, anorexic people can also purge. It doesn't matter, okay? They could also purge, all right?
So if it was of normal BMI, it would have been bulimia, right?
That is correct. So that's what I told you. The BMI is the only easy one to differentiate, yeah. But one more second, sorry. Even if they remove the BMI, you still have amenorrhea, so still it will stick to anorexic because amenorrhea is only for anorexic, not for bulimic because they are normal weight and stuff. Is that clear, folks? All right. Now, what is happening here, folks? 61-year-old woman recently finalized the divorce, right? Does that make sense, folks? Recently finalized, and then she moved to a different place. So do you think, is she sad? Is there anything in this question it says she's sad? No. So this is either adjustment disorder or generalized anxiety disorder, okay? These are the two options for you guys. How do you differentiate? Less than 6 months, adjustment, more than 6 months, generalized anxiety disorder, since it's only been 2 months, okay? What is normal stress response that's coming up in here? Even though that's not the answer, but here you should be fighting between this. So let's talk about F here. A normal response is differentiated from an adjustment disorder by milder symptom, a lack of marked distress, a lack of social occupational impairment. See, basically normal stress responses, you are doing everything what you're supposed to do every day. The normal daily activities, nothing should be disturbed here, folks. There shouldn't be any worries, nothing here. Are we clear here? So that's that, all right. So the incident happened 3 weeks ago, less than 30 days. What is there to confuse? Acute stress disorder. If it is more than 30 days, then you move here. Is that clear, folks? You see, even though it's an easy question, but sometimes we miss it because the problem is it's not about the question, the mindset of 1 minute you have to quickly answer it, right? That's why I tell most of the people who get the questions wrong, if you have more time, you will get it right. But you have to be able to scan it quickly, folks. This happened 3 weeks ago, okay? So that's the acute stress disorder. Is everybody clear, folks? All right, let's see. I have one more. So this, for the people who made mistake on the last question, make them happy. It happened 2 months ago. Is that clear, folks? So that means it's G here, more than 30 days, okay? So 30 days more, 30 days less. Let's see. All right, so that's the answer. Same PTSD, pay attention to the timing. Clear, folks? All right. All right, so let's quickly talk about the sexual dysfunction. I will give you a summary here, folks. I don't like how the book is differentiating. Now, when people have come with ED, okay. Now, even though it's a sexual dysfunction, the main problem is erectile dysfunction, okay. So erectile dysfunction is divided into two, right? So this divided into two. One is organic problem, and other one is non-organic problem, okay. Or other one, we could say, let's put it in this way to make it easy. One is structural, non-structural. Non-structural mean, folks, it's usually psychology. Okay, psychological issues. There's some anxiety disorder, depression, different things can be, anything to do with psychology. The only question you could ask to differentiate, these people with psychological issue will still have early morning erection. Is everybody clear, folks? Still have early morning erection, okay. So early morning erection, because it happened unconsciously, and psychology cannot do anything. So as long as they have early morning erections, that's considered non-structural psychology. Is everybody clear, folks? Now, people with structural problem, negative early morning erection, okay. So when you take a history, that one question makes the difference. Is everybody clear, folks? Okay. Now, no early morning erection. That means there's a structural problem. Now, sometime, then you ask the second question afterwards, folks, okay? Do they have difficulty getting an erection or maintaining an erection? So, getting an erection or maintaining an erection, folks, okay? So they will give you one of those answers. If they say they have difficulty getting an erection, it's a problem with the arterial system. If they say maintaining a problem, that's a problem with the veins. This is how you work down. Is that clear, folks? Okay, now that brings you to the question, what is the mechanism behind erections, right? So if I were to tell, this is the, let's say, penis, and you have a blood vessel like that, folks, okay? So I'm going to say this is artery and this is vein, okay? Now the mechanism behind it, when you bring in more arterial blood flow, the more blood flow you bring in, that's how erection happens. That's a mechanism. Is everybody clear, folks? Now erection happens. Now in veins, in here, there's a special valve, or we call veno-occlusion. Okay, so the blood is coming inside the corpus cavernosa and the erection is happening. Now, keep in mind, for you to maintain the erection, it's all about that veno-occlusion is happening in the vein. Is everybody clear, folks? Because if the veno-occlusion is not happening, the blood will go out faster than they lose the erection. Is everybody clear, folks? Now, very careful. Veno-occlusion, it's a term, it's pure pathology everywhere in the human body, except the penis, where the veno-occlusion is considered physiology. Okay, in penis, we do want the veno-occlusion. So veno-occlusion is only physiology there. Any part of the body, if you say in the leg, hand, veno-occlusion is a pathology, that's a clotting. Is everybody clear, folks? So that's the idea. So what happens? More blood is coming in, erection, and once it's done, then the veins will open up, all the blood will leave. When the blood leaves, we lose the erection. Is everybody clear, folks? Now, if a patient says, I have difficulty getting an erection, that means the patient is not bringing enough blood supply to the penis, which tells you arterial system have atherosclerosis and stuff. Is everybody clear, folks? Because when you have atherosclerosis, blood flow decreases. Is everybody clear? Now, if a patient says, I have no problem getting an erection, but I cannot maintain it, that tells you you have no problem bringing the blood, but the problem is to keep it there because the veno-occlusion is not happening for a long time, so the bloods are leaving faster. Is everybody clear, folks?
Can you explain how the veno-occlusion works here again, please?
So the veno occlusion, there's a special valve that's always closed. Only after ejaculation, the valve is designed to open, folks. Okay, until that, it should not open. If it opens before that, it's pathology. Is that clear? That's the idea, folks. Okay, now these are the two main problems. Now, when they say, most of the time, people would say getting an erection is the problem with the diabetes, a good example. That's where we develop, we prescribe, for example, Cialis or Viagra medication. What do you think the Viagra does? It's vasodilation, isn't it, folks? Right? It's vasodilation. When you do vasodilation, you are bringing in more blood flow. Does that make sense? So that's that. For venous problem, unfortunately, there is no treatment as far as I know, in the United States. Because you cannot create a veno occlusion artificially. That will block everywhere in the body. Is that clear, folks? There is no treatment, but still you could give Viagra, same medication, because as long as you bring in more blood flow continuously, there's a blood staying in the corpus cavernosa. So it can be helpful a little bit. Is everybody clear, folks? If that doesn't work, there's a prosthetic treatment. There's a different pumps and stuff they could do. You talk about that on step 2 and step 3. But just step 1, understand the basics here. What are the different type of problems? Is everybody clear, folks? Now, of course, there's an involvement of hormones and different things. But this is the best way to break it down. That's why taking a proper history is way so important. Is everybody clear, folks? All right. Now, let's move to here. Sleep terror disorder, high yield. There's 2 diseases, folks, okay? Night terror versus nightmare. 2 things. Okay. Night terror is like a screaming in the middle of the night, most common in children. Okay. So how do you differentiate when the night terror happens? Night terror is where the kids wake up in the middle of the night. It's not kids, even adults. They wake up in the middle of the night, they scream and cry, and they go back to bed. But when you talk to them in the morning, they have no memory. They don't remember. They won't trust when you tell this. Okay? That's no memory. No, that's why any night terror, it's no memory. Why no memory? It happens on non-REM sleep. When it happens on non-REM sleep, you cannot remember anything. Is everybody clear, folks? It is the physiology. Any activity that happens in non-REM sleep cannot be remembered. Which you walk, sleepwalking, night terror, all those happens in the non-REM sleep. But when it comes to nightmare, what is nightmare? Bad dream. You had a bad dream. That happens in the REM sleep. That happens in the REM sleep. So you have a good memory. So you wake up next day and I realize, I had a bad memory, a bad dream that I'm getting a low score on NBA. That's a bad dream. You remember that. Is that clear, folks? So when you remember, that happens on REM sleep. Whenever you don't remember, that happens on non-REM. Is everybody clear? Okay. Now, that's the idea here, folks. The triggers include emotional stress, fever, lack of sleep, and usually self-limited. I'll tell you a little story here. There are some days, my wife is a pediatrician, and when my daughter was little, when she was 3 years old, if she's in a night shift, I have to put her to sleep. And I want to put her to sleep as soon as possible, so I watch my episode on Netflix. Okay. So what I would do, she would not fall asleep. So I would have a lot of autopsy pictures of my pathology. I would show her and say, look at this head, how it's cut. Look at this thing, how it got. So she would get scared and go to sleep right away. Right? So I know, don't get me. So it sounds like it's working. 15 minutes, she's in deep sleep. She would wake up randomly and scream in the middle of the night. Okay. So she's like waking up and there was a time she's like, don't come me. That's what she was thinking. Right? And my wife was like, what would you show to her the night? No, just YouTube. Right? Then, of course, the kids don't know. So my wife asked my kid, what did the dad show you? All these awesome pictures from his dad. I don't know. Right? So my started by like, did you really show this picture to a kid? I said, I thought it would fall asleep. Of course, you're not supposed to do. And that fear folks, they wake up in the middle of the night, they scream. That is night terror. And when I asked the next day morning, why did you, Jesus doesn't do that. Right. So that's night terror. Okay. Don't do that. Okay. So that's the idea of okay. Now that's sleep terror versus night fears. Okay. Now next, endurance, bedwetting. Now there's a question. Now you see, when there was a question, hyperperfusion, right? Hyperperfusion will not tell the hyperperfusion is basically getting any that's exactly what it is. Low blood flow is hard to get. Yes, yeah. All right. So endurance is bedwetting. Okay. Now, one thing is, it's a nighttime urinary incontinence. It's completely normal after 5 years. Okay. This is so important to learn because they will give you a question saying that it is very every day or whatever they are 4-year-old. The answer option either normal or reassurance. That's very clear, folks. Because after the age of 5, it's completely normal. Okay. Only after 5 years of age, we think about it. Until then, they are good. First line treatment is behavioral modification after 5. Okay, I repeat, 99% of the time they examine is less than 5. So look for the option reassurance. Very important. More than 5 years, you will do a schedule, right? That means, you let them urinate before they go to sleep. Don't give them too much food in the night, and then also possibly reinforcement. Why does that mean? If you don't get started, if you get 10 star, you can whatever right? Something possibly reinforcement. These are the key. Now medication. When it comes to medication, there's two medication. Desmopressin or ibuprofen. You must know this person that I actually ask. Out of those two, this is your first choice, and the second goes ibuprofen has side effect. Desmopressin don't have because literally it's ADH. How does ADH help in this patient? It reabsorbs all the water, so the urinary output is less. That's the idea, folks. That's the idea. So this is also our you should be easy to tell the 3 diseases we studied. Desmopressin is an answer. 3 or 4 diseases. Okay. So all right. So that's the endurance. Will be okay, folks. All right. Next one, narcolepsy. When it comes to narcolepsy, this is an excessive daytime sleepiness. Right? Now, so this is important. Again, we have to differentiate. When people come with daytime sleepiness, when they come with daytime sleepiness, there's 2 different diagnoses. Sleep apnea, because they don't sleep properly, then they are tired throughout the day. Or narcolepsy. Everybody agree? Only one question you ask, that will differentiate. You ask the patient, do you feel fresh when you wake up? Fresh waking up. Do you feel fresh when you wake up in the morning? If they say no, that's sleep apnea. If they say yes, they are fresh, that's narcolepsy. Okay, that's the idea. Okay, that's the idea. Everybody clear, folks? Now also, I usually tell the students, you guys should ask yourself a question for the next 30 days. Every day when you wake up in the morning, ask yourself, do you feel fresh when you wake up? And if you think no, that means you didn't get enough sleep. Okay. If you don't get enough sleep, it is a bad sign towards your step 1 exam. No matter how much you learn, no matter how much you study, sleep is the most important thing in the world, folks. Okay. People who has a problem, they know the value of it, right? Even if you pay somebody $1 million, you cannot get a sleep easily, right? That's I am telling you. So it's important to sleep. because that gives you the energy and how you respond. Okay, very important. Now, so narcolepsy, they wake up fresh, but still they feel sleepy throughout the day. Recurrent episode is there, folks. Okay, overwhelming sleepiness more than 3 times a week for 3 months. There's a hormone called orexin. They say that could be less. That's important. That's a dysregulated sleep-wake cycle. There's a couple of things here. Hypnagogic, hypnopumpic, and all these things. These are like a little hallucination, not important. What's the most important is cataplexy. What is cataplexy? People with this disorder, they will lose all the muscle tone if there's a loud noise. So let's say these people will stand a huge loud noise. They will just fall on the floor. People think they fainted. They didn't faint. All they did was lost the muscle tone, but they could hear everything what you say. Okay, so that's exactly what it is, folks. That's cataplexy. Now, people with narcolepsy, they need a good sleep hygiene. So that means they know they have this problem. They have to schedule the nap. They have to make sure they sleep, regular sleep schedule. During the daytime, you have to take some stimulants. That's the only way they can stay up. If not, nighttime oxybate to get a good sleep cycle. That's narcolepsy. Everybody clear, folks? Okay. Next, recently, this has becoming a very high-yield topic, substance use disorder. Okay, substance use disorder and, of course, gambling disorder. Both, they all come with that, folks. Okay, let's take a look. Substance use disorder is basically, it's a maladaptive pattern of substance use. So how do you know that you have a substance use problem, right? One, you develop a tolerance. If you have to take more, or if you take it and you have no effect, that means you are getting the addiction almost, folks. Okay, a good example. Usually 1 drink makes me drunk, and let's say now 1 drinks don't do anything. That means I'm getting more tolerance. Is that clear, folks? Next, the minute I don't, you have a withdrawal symptoms. Third, intense and distracting cravings. I started using more longer than intended. So I'm using that. Persistent desire, but inability to cut down. You are not able to control it. Time-consuming substance acquisition, use, and recovery. Impaired functioning. After you do that, you are not doing anything, folks. You cannot work, you cannot study, nothing. And it conflicts with the social interaction. And you are not participating in a recreational activity. That's one of the best one. People who use, they won't participate like before. Okay, they won't come. More than 1 episode of use involving danger, folks. Okay, they can get in drive and get into trouble, unsafe sex and stuff. Continued use despite awareness of harm. They know what they are doing is wrong, but it's harming their body, but they still continue, folks. These are the symptoms. It tells you that they are getting addicted to substance. Are we clear, folks? All right. Now, just to talk about the word of addiction, right? Now, I was talking to a psychiatric professor. He was explaining, which makes sense to me. When we say I'm addicted to alcohol, let's say a word, right? It's not that definition of I'm addicted to alcohol is not that I wake up, I want alcohol. That's not a really addiction. The addiction is when I am working normally, I'm not able to do without alcohol. Is that clear, folks? I'm not able to function without alcohol. It's not asking for alcohol. So I could tell, okay, you know what? Okay, I don't have to drink. That's fine. But then I try to work. I'm not able to work. I need it. That's what the real definition of addiction. Does that make sense, folks? So careful. Now, next, gambling disorder, folks. Okay. Now, what is gambling disorder? It's a persistent, recurrent, problematic gambling that cannot be better explained, right? You need to have more than 4 of those. It's preoccupied with gambling, requires.
I'm sorry. Can I go back to substance use disorder? Sure. So does substance use disorder include addiction and also not being addicted, or is that like an all-inclusive term, or is it specific?
It's all-inclusive.
Okay. Yeah. Thank you.
Then here requires more gambling to reach the desired level of excitement, has failed effort to limit, cut back, or stop gambling. Most of the people gambling, they end up losing everything at the end of the day, right? So that's because of this. become restless, irritable when limiting or attempt to stop gambling. Sometimes people cannot stop. If you try to stop them, they will even kill you if you try to stop, because they want to do it, folks. Gambles to escape or relieve feelings of helplessness, guilt, any of those things. After losing money, this is important. This is what wiped them out. See, after COVID started, so many people went on to stocks, right? How many people heard about Robinhood, right? Every Tom and Harry was doing stocks, every time. You see, folks, majority of the people lost money. You might have heard some people made money. They only tell you when they make it. They won't tell you when they lose it. Okay, that's a reality. Stocks, right? People always say, when you do stocks trading, you could do as a professional or you could do as a gambler. Basically, somebody tells you the stock is going to go up, you buy it. That's gambling, basically, right? The real stock people, they read charts, they read so much news, they have a statistics, they have a plan. That's what it is. What gamblers do, folks, they buy it, they lose the stocks, and then what do? They buy again for the double the amount because they want to catch what they lost previously, and they end up losing everything. Is that clear, folks? That's the idea here, okay? Now, that, and then they lie, and then they put a risk of or lost significant relationship, relies on money from others, all these things, okay? That's gambling, folks. Now, this is a must, okay? This you need to know, it's not easy as what we think, okay? When somebody goes through what we call an addiction and they're trying to come out of it, that rehab, these are the steps that they go through it, folks, okay? Now, there's a couple of stages. Pre-contemplation, which mean they deny the problem, okay? I'll come back again with examples. Contemplation mean they at least accept they have a problem. Preparation or determination mean they already accepted they have a problem. Now they are willing to change it. They are willing to change it. Is that clear, folks? Action or willpower, that means they are in changing it. So they are doing it. Actual action is happening. Then they maintain it for a few days or whatever the time they are maintaining what they did. Then they go back. It's relapse, folks. It's a cycle. Does that make sense? Now, let's take an example, right? So people around me, they know I'm addicted to coffee. I do about 6 cups minimum a day, okay? I mean, what time is it now? It's 10 o'clock. I'm already on my 4th, okay? So that's how much. It's basically, even if I don't teach, I have to have next to me on the table. And then I maintain the temperature cup too. It has to be perfect temperature on there too. Otherwise, I get mad. Only coffee, nothing else. Sometimes, folks, I would carry the coffee the whole day in my hand. I won't drink it, but I have to have it wherever I see, right? I have that problem. But so many times people tell, and even my doctor, I never accept it. I was like, that's not a problem. See, when you deny you have a coffee addiction, that's pre-contemplating. I'm not accepting it. Is that clear, folks? Now, then what happened? Finally, I have no choice. I have to accept it. So I said, yes, I know I am addicted to coffee. So what? I'm not doing anything about it. So that's that. At least I'm accepting, but not doing anything. Is that clear, folks? Third one, I know I have a problem. I'm trying to cut down my coffee. So that I'm trying to cut down. Am I cutting down? No, I'm okay to try. Then finally, Friday comes and I said, today is my last cup of coffee. That's it. No coffee Friday afternoon, no coffee Saturday, no coffee Sunday. So it's all maintenance. Does that make sense, folks? So I didn't drink coffee Saturday, Sunday. That's maintenance. Monday morning, I go through drive-through, buy the coffee again. Okay, so that's relapse. Okay, now, then it starts again here, folks, with that. So the idea of the rehab, nobody becomes successful at once. It has to be multiple times. Is that clear, folks? Right? So that's the idea. Now, what they do, see the example I gave you, it's a very easy one, but sometimes they are giving a scenario in the exam. It's a very difficult one. Recently, I was told by a student, the exam they gave was, this person is addicted to some substance. Finally, he went online and he registered himself to a rehab center. Which letter for my scenario? So finally, he went and enrolled him on, he enrolled himself on their rehab center. You see, I'm getting an answer between these two, isn't it, folks? This is where the confusion comes. You could go online and enroll yourself to a rehab center. Nothing will happen until you go in person and admit yourself there. Is that clear, folks? Not everybody who enroll, that means they will go and do it. Are we clear, folks? So the question I tell you, it's C, preparation. The only time I will believe that that person is doing when they actually go in there and doing it. Is that clear, folks? So very careful. What's the situation? Okay, I have a question here. Let's try one scenario. Go for it. So here what you see, finally he accepted, he made an appointment with the counselor to talk about his option. That means he's still in the stage of preparation. He has not done anything about it. Is that clear, folks? The only time you could say action when they talk and when something happened to that. At this point, E is the right answer, folks. Okay. If you go for pre-contemplation, what is pre-contemplation? Denying the problem. Is that clear, folks? So careful with the terminology. Take this picture. You should, that's better. I mean, it's the same as your book, but I feel like it's a little better. Okay. So that's a stage of behavior change, folks. So this is what we go through always, right? That's the key. It's like you tell your wife it's your fault. They're always in pre-contemplation. They will never move to the next one. I always wonder, not even accept it, deny. That's it. It stops right there. Right? So that's pre-contemplation, folks. All right. All right. So that's that. Any question in here? All right. Good. Let's take a break. I got my second signal for my bladder. I have to go.